if you click that participants, which is there in the left hand side in the bottom, you will get to know, you have two options, panelists and attendees. In the attendees, you'll get to know all the doctors whom you may be familiar. Like you have Dr.
I think that's not completed. Let's remain it simplified, because now everything is on smoothly going.
Yeah, attendees are 65 already.
Dr.
74.
Verma, and now I think let's not do anything more. Let the screen be like this.
Yeah, we don't want to get disconnected again.
Hanji, sir, bilkul.
Perfect. So I think 75 we have reached now.
It will,
So
Dr. Skuja said, it is now, there will be rapid increase in numbers now.
Now, gradually it will go to 100. I think
something like coronavirus.
भाई आज नॉट इसका तो 4-5 हो रहा है कुछ.
जनरल वर्मा देखो चिड़ा चिड़ा के चाय पी रहे हैं सर. पानी पी रहे हैं साला, किस्मत की बात है.
पता नहीं उसमें डाला क्या है, जरूरी नहीं है चाय ही है.
देख लो साहब, देख लो अच्छे से देख लो.
वोडका भी पड़ा हुआ है इधर.
डालगोना भी नहीं है उसमें.
देखो वही मैंने कहा, वर्मा जी तो इंस्पिरेशन के लिए पता नहीं क्या क्या रखा हुआ है.
So it's 7:03. I suggest that we start.
Yes.
If it's okay with all the panelists.
Yes.
Yeah. Good evening, all the delegates as well as the audience. It's a great privilege to welcome each and every one of you for this first webinar from the nephrology portfolio, on which is supported by Microlabs Limited, which is a Bangalore-based company in India. It's been a real honor to have all the leading panelists of nephrologists across the country, in which we have Dr. P.P. Verma ji, we have Dr. A.K. Balla, we have Dr. Sunil Prakash ji, we have Dr. Vinay Sakuja, we have Dr. Vijay Kher, and all the seniors. So it's a great opportunity to welcome each and every one of you for this today's topic, which is basically COVID-19 and the kidney. So we have the fixed agenda, as you must all have received already. So I take this opportunity to welcome one and all of you, and thank you very much for sparing your valuable time. So now I request Dr. P.P. Verma ji to take over from here and introduce the speakers and then go into the overview about COVID-19 and the kidney. Over to you, Dr. P.P. Verma.
Thank you, Mr. Raja.
Yes.
And good evening, ladies and gentlemen. I, on my own behalf and on behalf of this illustrious, respected, and senior faculty, welcome you all to this webinar on COVID-19 and the kidney. In last couple of weeks, all of you must be hearing and must be gaining knowledge from webinars on different aspects of kidney. There have been talks about in webinar about dialysis, COVID and transplantation, and all these have been very, very useful and informative. I can only say that this webinar is a continuum of learning knowledge on the fields of COVID-19 and the kidney. We assure you that it should be a very compact and a practical type of webinar. Keeping in mind the rapidly growing field of COVID, as a matter of fact, I was just reading Dr. Horton of Lancet, who was mentioning that every day he is receiving 30 to 40 articles in Lancet for publication. And you can imagine about the other journals, what is happening. And many of these articles are getting published without peer review, and some of them are getting published straight away from desk. So therefore, whatever knowledge we are getting, some of them may be contradictory, some of them may get negated in near future. So what we will be talking today will be as we know today, and hope that it stays like that for some time. Just to introduce the panelists, I will be moderating the session. Then we have got, I'll also give a introduction and overview about COVID, little bit reference to nephrology. I'll be followed by Dr. Sunil Prakash, who is head of nephrology and transplantation at BLK Hospital. He shall be talking on AKI and COVID. This will be followed by Professor Dr. A.K. Balla Padam Shri, Chairman Gangaram Hospital. He shall be talking on a very interesting and important field of dialysis population and COVID, how to manage them. After that will be a very respected, my teacher and Dr. Bhalla's teacher also, Professor Vinay Sakhuja, Professor Emeritus at PGI Chandigarh, who will be talking on the testing, lab testing about COVID, when to do, what to do. And finally, a very revered and popular teacher, Professor Vijay Kher, he will be talking on nonsense of transplantation and COVID. So I think I will start with my topic, that is introduction and overview of this. The slide I have to move. Yeah, this is. So we all know that it is a story of almost last 3.5 months. 31st December was the first report of cluster of cases of pneumonia of unknown origin from China, Wuhan. It is a story of Wuhan and Hunanan. Very fast, in couple of days, this virus was identified as coronavirus 2 through the bronchoalveolar lavage of a patient. So initial some cases were associated and related to Hunan's a seafood market, which, for your information, got closed on 1st of January this year. February 11, WHO renamed the disease as COVID-19, that is coronavirus disease 19. And a month later, on 11th March, they declared it as a pandemic. If you look at the magnitude of the problem in 3.5 months, where we are, today we have got almost 2 million cases of this disease. 30% of the load is shared by USA alone. Almost 48% of the burden is in Europe, and rest 20 to 25% is being shared by rest of the world. If we see today, we have got over 2 million cases. There have been unfortunate 120,000 deaths, and the disease has engulfed and created terror in 210 countries. If you look at on the economic front, this has been a very, very bad time. Over $1 trillion have already been lost. After many years, the GDP of the world has dipped below 2%. And the global economy has already shrunk by 1%. And if the same thing continues, we may be heading for a doomsday in economy. Well, coming to the first publication which appeared in Lancet, that was 41 cases of pneumonia in China. And these cases, almost 2/3 of them were having history of exposure to Hunanan seafood market. Well, after that came the next publication of 425 cases of pneumonia, again from China. And if you can see the dark brown bars below, these are the association with seafood market. But logically, once on 1st of January, this market was closed. After 14th of January, there is no association. And today we know that disease is spread from human to human. Now, if you look at the intermediate host, we know that the virus has got a homology with bat virus, 88%. It is coming from bats. But unlike the SARS and MERS virus, where you had the intermediate host, whether it was a civet cat or it was a camel, we do not know what is the intermediate host for this virus. Pangolin is basically an anteater, what we find in our forest. This is a scaly creature, almost a meter long. It survives basically on worms and ants. It licks them. The pangolin was thought to be the culprit, intermediate host, because they found that 70% of the pangolins were harboring this virus. And one of the studies pointed out that 99% homology with human coronavirus was there. And as I said, the science is changing. This was contradicted soon when they said it is not a total genetic homology. It was only some attachment portion, attachment of study, attachment, the binding area, which was studied only which had homology. So this pangolin theory was also given up. As on today, we are not sure what is the intermediate host. I think time will tell what it is. Well, coming to the pneumonia and the risk factors, this is the largest data which published last week in JAMA. There's a data of almost all cases which occurred in China, 72,000 cases, and 62% of these were confirmed cases. As you see, the disease, as we all know, that in 80% of the cases, it's a mild disease, and 20% of the cases, it is bad. In 15%, we call it severe, and 5%, it is really critical. Now, who are the people actually who are going to develop this critical or severe disease, or what are the risk factors? If you look at, this is the data from 3 studies which have come from China. If you combine them, you will find that practically 2/3 of the patients had one or the other comorbidity, that is either hypertension, diabetes, coronary heart disease, or cerebrovascular disease. Now, if you look at the US data, which got published just 3 days back, they just studied 7,162 COVID patients. These are not serious or any other patient, just normal COVID patients. And they find that almost 37, almost 40% patient had some comorbidity. And if you look at the hospitalized patient or critically ill patient, it was 70 to 80% of the people had some or the other comorbidity. So what is important is the comorbidity. If you look at the effect of age, this is the Chinese data on elderly, the fatality data. As you find that people who are over 80 years of age, the mortality is almost 15%, and younger population, there is probably practically no mortality, or 0.1 to 0.2% mortality. Now, if you look at the Italian data, the fatality in Italy is 12.7% as on today of the total cases, because Italy has got the second largest elderly population in the world. Japan is the leader. They have got the maximum number of elderly population, followed by Italy, where 23% of the population is over 65 years of age. Mind you, in India, 6.1% of the population is over 65 years of age. And almost 99% of these people had at least one, and 48.6, almost 50% had 3 or comorbidities. So what is important is to accept that it is the advanced age and presence of comorbidities which gives the risk of fatality for this virus. Coming to the mode of transmission, we all know it's a droplet transmission, but in between there was a theory which came that aerosols are also causing it. We know the size of droplet is more than 5 microns, and aerosols are generally less than 5 microns. This was a study which came in NEJM on 17th March, a month back. What they did, they generated aerosols, were generated by use of 3 jet collision nebulizers. And after generating it, they put it in the Goldsberg drum to create an aerosolized environment. Then they brought out that the aerosols persisted in the drum for over 3 hours, creating a fear that possibly the aerosolized form, if it is there, it can remain infective in here, which created a fear in people's mind. And they also, in the drum, they placed different metals. And if you see the brown one, this is with our coronavirus 2, that is COVID. And this is blue one is the SARS virus. What basically you are finding with copper and cardboard, the contact period is not much, the virus dies, but with stainless steel and with plastic, it is more. After they published that, a clarification came from WHO. As I said, whatever you publish, again, the clarification comes. The recent publication they mentioned, it's the WHO language, the recent publication in NEJM has said persistent of COVID virus. They said this is an experimental study. The generation of aerosol is by 3 jet collision nebulizers, which are fed. This is a high-powered machine, which is not in natural condition, and don't remain fearful about that. And they said further, the finding that the particle remain up to 3 hours does not reflect a clinical setting. But what is important to know that aerosolized form can stay there. So there are some subset of patients, like for example, if somebody is getting a CPR, somebody is getting a mechanical ventilation, somebody is getting a tracheostomy, somebody is getting an endotracheal intubation, somebody is trying to be made prone from supine position. These are the situations when the aerosol form can come. So one has to be careful about such settings. The last point I want to discuss is, which is again intrigue, how the disease, how the virus is actually causing the disease. We know that there is ACE2, angiotensin converting enzyme 2 receptor, which is there at many areas in the body. For example, on tongue and in mouth, there is very high density of ACE. ACE is found in lung, especially the basal lungs. ACE is found in kidney. ACE is found in intestine. It is found in heart. It is found in blood vessels at many places. Now, what happens? The coronavirus is called corona. Corona means a crown. So the virus has got crown, S protein, the spike protein on this. Now, this spike protein has to get attached to, if you look here below, I'm pointing out this. This is the ACE2 receptor. So first it has to come in contact with this and bind it. Once it binds, then the second step is there's the transmembrane receptor, serine based, and then this has to do the priming. For example, if you look at, this is a ACE, this is the virus comes, it has come and bound. Now the other portion of the spike protein will bind. This is again more and more will bind. Eventually, you find all over, these are ACE and ACE, and the virus proteins are bound. After it is bound, eventually, then the TMPRR, transmembrane protein, this causes a priming of protein, and only after that the virus enters it. Now, this is only a diagram which is trying to show that what is important is the receptor binding domain, the RBD. Because the research will be, if you can create some antibodies against receptor binding protein, possibly the binding will not occur. Now, if we go by steps, so we say, this is the last slide of mine, ACE2 expression besides lung is also seen in liver, heart, kidney, and blood vessel. Virus spike protein fuses with ACE2 receptor before entering. Then the TMPRR interacts with the receptor and primes it. Inside the cell, it fuses with endosome and multiplies in the acidic milieu. In patients who are taking ACE inhibitor or ARBs, there is upregulation of receptors. Anybody will say, if there is upregulation of receptors, logically more virus is going to bind. So this is going to be dangerous. And once again, another point, the people who are believer in chloroquine hypothesis, one should know that chloroquine, once it goes inside in the endosome, it creates a basic pH. From acidic pH, it is changing the pH towards base. So therefore, in the basic pH, the virus cannot multiply. They believe that possibly one of the hypotheses that it may be working there. Anyway, coming back to the same point, if ACE and ARBs are upregulating the receptor, so what is happening? Why the disease is not occurring more? We really don't have a fixed answer, but possibly it may be a hypothesis that if there is increased upregulation, that also may be there is increased shedding of receptor. So if this receptor is shed and lying in the alveoli, this might be taken as a decoy receptor for the coronavirus, which might be binding there. Or it is also possible that in the upregulated, once the spike protein fuses with that TMPRSS does not interact, or it does not prime it. It may be possible that ACE, which creates angiotensin 2, causes some configurational change in the receptor. Therefore, the entry of the virus is inhibited. What we know today, that if you downregulate the receptor, disease is more severe. If you delete the receptor by any antibody, disease will be more severe. If you upregulate, Rather, the trials may be if you can give ACE receptor to people, if you can give ACI to people, the trial is also on that if it can prevent or make the disease milder. Well, this is where we are today. I think I will stop here. Now I will invite Dr. Sunil Prakash, who will be talking on AKI and COVID. As I mentioned, we also know today that AKI, I will not dwell, he will dwell on that, how common or how uncommon is this, why it is occurring, and whatever it is occurring, what form of RRT we should give it to them. Over to Dr. Sunil Prakash, please.
Thank you, General Verma, for a very excellent position of the talk. You have set the ball rolling, and I wish to welcome all the listeners who are there. Welcome. And as we get going, I just want to start that this problem is, as we all know, it is by the cough and sneeze of the patient who has the virus. And normally it will go up to 1.5 meters. And that is why the recommendations are to keep at a 2-meter distance. So if somebody is at a 2 meters distance, most of the virions will fall behind. But once in a while, if somebody has a large spray like nebulization or something, then maybe it may go even up to 6 meters. So once in a while, especially in procedures and suctions and nebulization, one has to be extremely careful, and they are rather contraindicated. Friends, we all know that initially, in most of the people, the symptoms may be very mild. There may be fever, which may not be very challenging. Then some cough, which is mostly dry. Diarrhea, headache are common. And if you do a lab at that time, you have lymphopenia, some deranged prothrombin time. Remember, it's a coagulant state. And you have increased D-dimer and a mild rise in LDH. Normally, these tests are not done at this point of time. And as the virus has set in the body and they are going down slowly, where is the problem? The problem is the host takes place in a very big way. The inflammatory response of the host sets the ball rolling in a negative way. The person becomes hypoxic, doesn't maintain the saturations over time. You have abnormal chest findings, you have transaminitis, you have low procal, and it is mostly the pulmonary phase which is going from bad to worse, to a point when it may land up into adult respiratory, acute respiratory distress, shock, cardiac failure, renal failure, and you have a plethora of the labs sitting here. You have CRP, LDH, IL-6, D-dimer, ferritin, drops, and pro-BNP. Everything's up there. And this is, so in other words, we can also say a person who has a very aggressive immune response maybe will have more severe outcomes. And possibly that is why, as we notice, in CKD patients with their poor immune status, they do not mount such a vehement pulmonary response. And at the bottom, I have shown some therapies which are being worked upon, and they would be acting at different levels. And I think subsequently they will be covered. So how does it get going? As Professor Verma had told you very elegantly, the virion finds its way inside the body, the mucosa. It comes to the antigen presentation, and the same process goes through. It goes through cell immunity, where CD4 cells and CD8 cells are activated. It is presented to the cells, and the B immunity also comes into the picture, and subsequently memory cells are formed. But the problem is that the both immune processes lead to increased formations of cytokines, ILB1, IL6, IL8, CXL10, CCL, CL3, CCL5. And there's a very severe immune response to the lungs, which leads to ARDS and shock and all those things. So it is basically the cytokine storm, which is such a huge problem in these patients, and they require very intensive management.
Doctor, sorry to interrupt. I'm sharing your screen. I just wanted to know if it is correct, sir.
Sir, you let us know when you wanted to change the slide, he will change it for you.
Okay. So,
So can you see the screen?
I've just put on the new slide. Is it okay? Is it going? The slide's going?
1 minute. Sir, no, sir, you have not shared the screen. I have shared it.
Oh, so I think I'll shut off my screen. I think there's
Yes,
some
sir.
problem
Yes.
there. So maybe I'll go. Is it okay now? So you're holding on to it. Perfect.
Yes.
So we just talked about cytokine storm and the implications like ARDS and all. Can I have the next slide? Next, please. And this is about the virus. The virus has many proteins. The M protein is responsible for the transmembrane transport of the nutrients. And subsequently, when the virions multiply in the cell, it helps in the release of the bud after giving them an envelope. But the cake of the matter are the S proteins, which are S1 and S2 types. It is the S2 type which is of interest to us, and this will mediate the viral cell response by fusion with HR1 and HR2. Next. Next, yeah. So the S2, no, just go back, please. The S2 subunit contains a fusion peptide which will fuse with the cell. It has a transmembrane domain and a cytoplasmic domain which will see through it through the cytosomes and cytoplasm. And friends, many antiviral drugs are also being worked upon to act at this S2 level as an anti-S2 therapy. So once this S2 gets going, then you have some N proteins and E proteins. Their functions are not really well understood by us, and some single-stranded RNAs are sitting there. But all in all, we are concentrating mostly on S2 proteins and M proteins to understand the pathophysiology, multiplication, and the further implications of this virus. Next slide, please. And Professor Verma shared this slide. Suffice to say that he dwelt at length. And it is the binding of S protein on ACE receptors and DPP4 which causes injury through its cytopathic effects, cytokine release, and other mediators. Friends, we all know that ACE is almost 100-fold high in kidneys than lung. So I was perturbed that since it is so high titers on the kidneys, kidney will have a very big hit. But subsequently, my slides, as I've gone through the literature, have brought out a reasonably confusing picture. So I assure you, I leave you as confused as I am as of now. Next, please. Symptomatology in passing hypoxic, you all know, they have very difficult times to maintain saturations, hypotension, then new onset organ dysfunction, kidney by creatinine being up 50% from baseline or reduction in urine output to less than 0.5 mils per kg for 6 hours. And then if GCS score is down or any other major organ dysfunction is a sign of a big problem. Next, please. So pathogenesis is unclear because whenever many etiologies are implicated, so pathogenesis is unclear, but there are interplay of many factors. Most often it is ATN due to dehydration leading to a pre-renal failure. Then toxic tubular damage has been implicated by massive cytokine storm with or without rhabdomyolysis, cytopathic action of the virus that invades the ACE-expressing cells on the kidneys, on the tubules, and causes AKI, and then drugs which are given also bring in their problems. Next, please. So all in all, cytokine damage, organ crosstalk, and systemic effects of the disease will bring down the kidneys. Next, please. So here, the cytokine damage, and this slide tells us what we can do about it at this point of time. So in cytokine release syndromes, which may be due to the disease itself, and when we bring in ECMO, we bring in invasive ventilation and or CRRT, it also on one hand causes cytokine removal by various approaches, but at the same time, it may also aggravate the cytokines, which we know in ECMO and other situations also. But high dose CRRT without ECMO and other modalities are being tried in very, very sick patients. Then organ crosstalk, cardiomyopathy sets in with or without viral myocarditis. You have cardiorenal syndromes type 1 acute. People have been given LVAD and AV ECMO. Alveolar damage, renal medullary hypoxia is associated with this. Again, veno-venous ECMO or CRRT would help. High peak airway pressures, intra-abdominal pressures could also lead to AKI by renal compartment syndrome. Again, one would need CRRT. Rhabdomyolysis, we all know tubular toxicity. same old story, requiring CRT with or without ECMO. Then systemic effects are like positive fluid balance in these patients will give you renal compartment syndrome, endothelial damage, third spacing, rhabdomyolysis, and endotoxin causing septic AKI. And there is some papers which suggest role of polystyrene fibers with polymyxin, etc. Next slide free to remove them. So incidence of AKI is very variable in all the papers. Exact incidence of AKI with COVID is unclear. But what we know is that in ESRD patients are exceptionally vulnerable to this infection by virtue of their poor immune status, and they may require in-hospital status. Next, please. This is a report from Chung et al. He had 700 patients, 52 were males and 42 were severe, and nearly the same about comorbidities. And the kidney abnormalities which were found was about 13-14% of raised burn, creat, and loss of GFR, decreasing GFR, and 40%, 44% had proteinuria, 26 had hematuria, and 5.1% were reported to have pure AKI. And he has shown a negative association of all these factors of AKI. And he has concluded that clinicians should be specially aware of the AKI in these settings. So this came up in Kidney International last week. Next, please. COVID infection is a special threat to patients on dialysis, which Professor Bhalla will cover. In this paper from Wuhan, there were nearly more than 7,000 patients in 61 centers. But in one center in this paper, they had 37 patients out of 230 who developed COVID infection, and 7 died. But 6 had causes not related to COVID. They had cardiovascular causes and not directly related to COVID. So this is what it said, but patients on COVID had less lymphopenia, lower serum levels of inflammatory cytokines, and milder clinical diseases than other patients with COVID-19. Possibly because we understand this is due to their poor immune status, that they do not come as a classical ARDS like non-CKD would come. Next, please. So AKI available data suggests that the prevalence of AKI in CKD is low in a Chinese cohort of more than 1,000 patients, in which 93 were hospitalized, 91% had pneumonia, 5.3 were in ICU, and 3.4 had respiratory distress ARDS, but AKI was seen only in 0.5%. And so in this study, at least the AKI per se, de novo was not so common. Next, please. Then Cheng et al. In this study said that they are fairly common. He said 44% had proteinuria, and creat was deranged in 15% of patients, and AKI occurred in 3.2% of patients. He also said that patients who do have kidney impairment will have a very high risk of in-hospital death. Next, please. So coronavirus, this paper says 19 does not result in AKI. He had analyzed 116 hospitalized patients from Wong's group. Next. But Medrex preprint on kidney function 59 patients by corona reported 63% showing proteinuria and 19% had deranged KFT. CT scan showed abnormalities of the kidney in all the patients. So he contradicts the above paper and says that AKI is not so uncommon. Next, please. Then Zhen et al. Included 193 patients, of which 128 were non-severe, 65 were severe, and 32 died. Of the 28 patients of other pneumonias were also included prior to its COVID outbreak to compare. So in the hospital, a fraction had a kidney dysfunction, which was significant, 59% with proteinuria and nearly 15% with deranged KFT. So he said AKI, although was mild, but if it was present with pneumonia, the outcomes were very guarded. Next, please. And these are various case studies. I will not go into detail, just concentrate on this bar. And the variation of AKI is from 0.5 to nearly 19%. And so I think I'm sure the jury is not yet out about the prevalence of AKI. Next, please. And here, what they are trying to show is AKI with mortality. So in this 4% AKI, if the creatinine was more than 1.5% on presentation, it rose to in 45% to deranged KFT before death. And mortalities were again variable. But one thing is coming up very clearly, that if a patient had AKI, for example, in this Chen's study Out of 29, 28 patients succumbed to illness. And in this also, they showed a very high mortality, 23% had AKI, and of all them, 11 had CKD. So if they have a AKI, 27 or 28 died in this group. Next, please. Finally, friends, all I can say is that this slide just tells us the amount of good work that is going on. We do not have to end on a negative note. Lot of work is going on at all level of the virus interaction with the human body, and they are working on it. For example, at this chemostat, mycellate has come in. They are working on it here, tocilizumab, sarilumab, and then structural protein, and then you have lopinavir, darunavir sitting here, ribavirin and favipiravir acting on RNA-dependent polymerase, and so on and so forth. So I personally believe that the mankind will win over this very formidable foe, and I'm optimistic about it. It's just a matter of time. Till such time, social distancing and being very, very vigilant and bright is the way to keep. Thank you for your very patient hearing.
Thank you, Sunil, for giving an overall picture of AKI. What you rightly said, the incidence may not be very high, but if it is there, the mortality becomes pretty high. Well, the next speaker, we will have questions at the end. The next speaker is Professor A.K. Bhalla. In between, Sunil did mention that a Wuhan study, that is a solitary study, that patients had, CKD patients, dialysis population had COVID, but possibly they had a milder form of disease. Is it really true? And the big but important thing is what is bothering everyone, how to manage our dialysis population and dialysis scenario. Professor Bhalla, please.
Thank you, Jana Verma. May I have the slides, please? Good evening, all the panelists and all the colleagues who have joined this webinar. Now, we have all seen hepatitis B positive era, then we saw hepatitis C positive era, and then we had HIV positive era, and now we have faced a fourth one, that is now COVID-19. There was all the time, there was a scare. Whenever we used to see a patient of hepatitis B, there was isolation and no technician, no nurse used to touch the patient. Then the dangerous one came, hepatitis C virus, where there was no vaccination, and then there was a risk of transmission. But then HIV was real era when the really technicians, nurses, doctors were avoiding these patients. But here is a disease which is highly contagious. And this is a pandemic. And in a pandemic, even healthy population is being affected, diseased population is being affected. So that is a real cause of worry. And hemodialysis patients who are definitely cannot be spared whenever there is a pandemic. We don't know, it is said that maybe 60 to 80% of the population will get infected due to this COVID-19 infection. We are still only 3.5 months old with the knowledge of this virus. So there is total scientific experience is not with having any randomized control studies. So whatever whatever studies are there, they are such a very short period and without much evidence-based journals and publications. So we have to bear that. Now, what makes these patients vulnerable or susceptible? Because of pre-existing comorbidities, repeated unavoidable exposure to hospital environment. They are coming twice or thrice a week, and for years together, they are being faced with other infected patients in the hospital. Immune spread state due to CKD stage 5, and maybe that is helping in our favor in these patients that already highlighted that we don't get that kind of cytokine storm in these patients. Like hepatitis C virus or hepatitis B virus infections didn't cause fulminant hepatic failure. So on the same logic, we do not get that kind of serious complications in these patients. They are prone to develop complications as compared to general population, otherwise also because of immune spread state and secondary infections, septicemia, short ICU admissions. And the symptoms may not be classically seen and may be due to different symptoms because of immune spread state. As already highlighted both the speakers, The main study was from Wuhan, where 237 patients, the 16% of dialyzed patients became COVID-19 positive. But the point to be seen here is that out of these 16 patients, none of the patients died because of complications related to virus infection. They all died because of either MI or CVA or other things, but not because, again, highlighting the fact that they did not get that kind of severe disease. And again, another point of concern is 12% of healthcare workers became positive in that study. So that is a very, very important, because this virus doesn't spare anybody. That is the reason that we are all scared in how to handle dialysis patients and how to handle dialysis units. And now, once we had this concern that dialysis patients are at higher risk, then Indian Society of Nephrology became active. And I was also part of this guidelines. So we made certain guidelines, and we presented these guidelines to Ministry of Health and Family Welfare. And after that, the revised guidelines were circulated by Ministry of Health and Family Welfare throughout the country. And by and large, these are the guidelines to be followed by all the hemodialysis units in the country. Now, these patients, first of most important thing is, the first thing the patient comes is, as you have already seen, patients are very much scared to come to dialysis unit because of risk of infection. Even patients do not want to come for blood test to the laboratory. And if we tell them to come to casualty, somehow they want that they can show us in a clinic outside, but will not like to come to. So here is a patient who will like to shift from thrice a week to twice a week dialysis, from twice a week to once a week dialysis. I am sure everyone will be facing this problem. The patients on regular dialysis should adhere to prescribed schedule and not miss their dialysis session to avoid any emergency dialysis. I think this is the point you have to highlight to your patients and stress it that if you miss the dialysis, then emergency dialysis may not be possible at your center. Now imagine like here you are sitting in your dialysis unit. So how will you plan the things in this situation? So all units should instruct their patients to recognize early symptoms of COVID-19 like fever, sore throat, cough, shortness of breath, dyspnea, rhinorrhea, myalgia, body aches, fatigue, and diarrhea. And please mention these three, fever, cough, and sore throat, that there you have to make a performa and get that performer filled up from the patient, where you must have their history of any place where there was a focus of patients or cluster of patients, or like we had in Delhi, then whether a patient had any history of foreign travel. So every dialysis, you must get the performer filled from the patient. Stable patients should be encouraged to come to the unit without any attendant, because the practice had been at many centers that one attendant used to sit with the patient, and that I think you have to strictly abolish that practice, and you have to reduce the crowd to the minimum in the dialysis unit. Now you have to have a screening area, if you can afford that, before you enter the dialysis unit. Make a small area or in the corridor, small, where you have to first screen the patients with adequate spacing and social distancing. It is very important. Every patient should be asked about symptoms, history of contact, then whether any travel to, as I mentioned. Then symptomatic patients, they have in the guidelines mentioned that every patient need not have face mask, but symptomatic patient only should have face mask. But in our dialysis unit, and I will recommend here also, now even government of India has also, at least government of Delhi has made it mandatory to wear face mask for every person, whether healthy or diseased. So I think face mask should be mandatory, whosoever is entering the dialysis unit. You have to provide the sanitizers at the entry so that they wash their hands they sanitize their hands properly. Now coming to testing as well as referral, all suspected patients of COVID-19 should be tested with real-time PCR test as per Government of India protocol. Now this is very important that your patients who are old patients on maintenance hemodialysis, if you get these symptoms, then you should send this patient to your flu clinic or a fever clinic, which I'm sure every hospital will be having. That should be in the emergency room or casualty. So that is a practice, in fact, at our center, that whenever we find any patient with fever or cough or sore throat or severe myalgias or unexplained breathlessness, then we send the patient to our emergency and we test the real-time PCR. And FDA has approved a test that is qualitatively identifying immunoglobulins, IgM and IgG antibodies against SARS-CoV-2. The serological testing will be an important tool to understand the population immunity and distinguish these individuals who are at lower risk of reinfection, or whether this will show us whether there is any development of herd immunity in the population, and especially healthcare workers. Now, once the patient comes into dialysis unit, the suspected or positive COVID patients, we should have, all these patients should have disposable 3-layer surgical mask throughout the dialysis session. So no patient in dialysis unit should be without mask. Patients should wash their hands with soap before dialysis, and you should train their patients this tough etiquettes, like cover your mouth with tissue, and that tissue paper should be thrown in the dustbin, and every machine bedside there should be a dustbin on every bed, so that you have the dustbin also individually for every bed, as well as tissue papers on each bed. Now, if patient is suspected or positive patient, then ideally this patient should be dialyzed in isolation. Although guidelines, that's why the revised guidelines came, because every center may not have separate hospital, right? We are lucky to have at Gangaram Hospital, we have a separate hospital, a totally separate building, which has been designated as a COVID positive hospital. So no COVID positive patient will be admitted in our main building of Gangaram Hospital. If you cannot afford that, then you can do is, you can have an isolation room in the dialysis room, but that room should have a closed door. So you should have a separate staff dialyzing these patients there, and those they should have all PPE of level 3, like we handle these COVID-19 positive patients. If you don't have an isolation room, then you can still manage with the last shift of the day, and then patient may be dialyzed at if still you can do that, or you can even dialyze the patients in the row end, in the end of last machine within the unit, ensuring a separation from all other patients by at least 2 meters. Now, for dialysis staff, in fact, protective equipment, this personal PPE is must, but the level may not be 3 as handling positive patients, but at least you should have shoe covers, you should have a gown followed by a plastic gown, gloves, and a mask, which should be preferred. If you can afford N95, that is preferred. If you don't have N95, then even circular mask. But face shield is very important, because that will prevent the droplet infection in these patients. Separating the equipment like stethoscope, thermometer, oxygen saturation probes, blood pressure cuffs, in between the patient shifts, you must clean and disinfect all this equipment. That is what we are doing at our center. That in between the shifts, with 1% hypochloride, you have to sanitize the building, this bed, as well as machine, stethoscope, BP apparatus. All these things have to be sanitized in between the shifts. It may take some extra time, but this is a mandatory requirement. This is just to show that how we have totally stopped attendance in our center, and see that we have a proper 6 feet distance between the machines, and that is how our unit looks like. We have 3 main cubicles like that, and this is one of our dialysis technician. That is how we are following at our center. He is wearing a face shield also. Now, these healthcare providers should still report temperature, absence of symptoms each day prior to starting work. So we must have a thermostat available at the entry, so that every patient as well as healthcare worker, we record the temperature. And if the face mask, I already have, and the sufficient quantity of face mask should be available, so that there should not be any shortage, because the mode of entry of infection is via nose, mouth, and eye, through eyes. And so this face has to be covered. That is the most important thing. Preferably, you put these technicians and nurses on 6-hourly shift, so that you don't put them on very long shifts. And every 14 days, you should have a rotation. If you can afford, then you can make 2 teams. So one team will work for 14 days and another team will work for 14 days. That will be further doing the prevention of spread of infection. But the thing is that we have a incubation period also, which varies from 7 days to 14 days or even longer also. So that somehow incubation period, one cannot be very sure even when you get a report as negative. Plus you have false positive and false negative reports also. So to counter that, I think best thing in today's scenario will be that every patient you presume to be COVID positive unless and until proved otherwise. So what is the answer for that? Universal precautions. As we were doing in HIV patients, I think same thing holds true today also. So all universal precautions must be strictly followed. Hand washing, these 7 steps we know because we have been handling CAPD patients since last about 3 decades. So our patients also know very well. So I think now this has to be practiced in hemodialysis patients also, as well as healthcare workers also. Then hand hygiene already highlighted. If you don't have the sanitizer available, at least soap and water is readily available. So at least minimum 20 seconds of washing with soap should be mandatory if you don't have the sanitizer. And if you see the hands are soiled visibly or dirty, then you ask them to wash first with soap and water and then with sanitizer. With sanitizer should be having at least 60% alcohol. Now, once we, as I mentioned, in between the shifts, you sanitize with hypochlorite. But in the night, what we do is that we usually formalize the machine with either hydrogen peroxide solution or silver nitrate solution. Now, these days, we are not using formalin, but best is to use hydrogen peroxide. And or you plus you do sanitization with the 1% hypochlorite. This has to be treatment has to be done for bedsides, routers, dialysis machine, doorknobs, light switches, countertops, handles, desks, phone, which is very important that every phone has to be sanitized, keyboards, toilets, and sinks. Ask the patient to not discourage them to bring phone in the room because phone again can spread the infection. It is like any fomite causing the spread. Then second is that avoid outside eatables during the dialysis. So for that, what we have done is our dietary department is giving us the support. So they are giving proper meals during the dialysis session, and only one person comes from the dietary department and he distributes the eatables. So no outside eatables to be allowed in these patients. All hemodialysis should be aware of the testing, triage, and notification policy. It is very important. It is a notifiable disease, and every patient has to be informed to your health authorities. Like in Delhi, we have Ministry of Health. Then even at the central level, you have Ministry of Health and Family Welfare. And if somehow somebody doesn't explain, notified it, then can be a serious FIR against you and police action. Already we have faced this in Delhi in one of the hospitals. So be very careful in notifying every patient who becomes positive. There is a proper form available for every center, that is ICMR form. That form has to be filled. And another, if unfortunately some death occurs, then how to dispose of the dead body again is very important. A proper pouch has to be there. You have to inform, and whether that how to cremate the body, where to cremate the body. All these things you should know rather than just handing over the dead body to the attendants and then creating the spread in the community. As far as treatment prophylaxis is concerned, suppose some patient becomes positive in your dialysis unit, then there are various limited data as far as HCQS is concerned, and we don't have any randomized control study. And whether it is a fact or fiction, whatever it is, the practical point is the practice is that most of the places are already using HCQS as a prophylactic dose, 400 BD on the day 1 if there is exposure, and then after that 400 milligram once a week till the pandemic settles. That is and we know as a nephrologist, in SLE, we are using this HCQS for years together. Rheumatoid arthritis patients are using it for years together. So it is a quite safe drug. And although I don't actually can't recommend it because we don't have the solid evidence for that, but I can also say that there is no harm. In one of EDTA study, they have even shown in dialysis patient also 200 milligram after every dialysis if patient is exposed to this HCQS. And for healthcare, already I have mentioned the dose, 400 BD first day and then once a week. But you should be very careful, especially when you use it in combination with azithromycin. Then it can cause prolongation of QT interval. And of course, eye changes are there if you use it for longer time, but not for if we were using it for a short duration. Now, there are we have a large population patients who are on CAPD also. One advantage of CAPD patients is that there is a very real social distancing already in these patients. As far as hygiene is concerned, definitely these patients are much more concerned and knowledgeable about personal hygiene and sanitization. So that advantage is there. So the recommendation is that those who are on PD, continue PD only. And as far as once they become positive, then you have to continue same practice. But only thing is that dialysis bads and tubing should be then disposed of after sprinkling 1% hypochlorite solution in the bed, then dispose of it in a sealed bed, and the fluid should be drained in the flush. Avoid putting new patients on CAPD. In fact, now these days we are not putting any patient on new insertion. We have stopped because sometimes there can be risk of infection spread to the anesthetists, to the surgeons. So better not to do elective surgery during these days. Acute PD is recommended if there is a need where patient cannot be put on hemodialysis. Now coming to acute kidney injury, all modalities of renal replacement therapy can be used depending on the clinical status and condition of the patient. If hemodialysis, preferably do bedside, like most of the patients are in ICU, and we have 4 machines kept in ICU only, so that with the RO plant there, so we can do the dialysis there only. If you don't have that, then you can have a small portable RO plant also, and so that it can be done there. CRRT can be done routinely. Only thing is that this steroid bads should be disposed of by putting 1% hypochlorite in the pads. Other therapies like cytosorb, there are studies which show that cytosorb has been used for tackling the cytokine storm in these patients. Similarly, auxiliaries also have been tried, but still we don't have many studies. But only I think yesterday FDA has approved use of cytosorb in patients of AKI with cytokine storms, depending upon their interleukin 6 levels and other markers. High volume hemofiltration and adsorption may theoretically be expected to give benefit in these patients. In one study, a high volume filtration of more than 6 liters per hour showed cytokine reduction and improvement in scores in septic patients. From the references for this study have been from Indian Society of Nephrology Working Group Guidelines, a Chinese Society Nephrology Guidelines, and these are the various papers published in Kidney International, Nature, CJSN, and one study from CDC.
I think,
yes.
Dr. Bhalla, thank you very much. Very exhaustive, and you have covered not only the dialysis population, you have also covered what the acute kidney injury also. We are running short of time. May I request Professor Sakhuja to please speak on the testing lab diagnosis of COVID-19. We also know that CKD patients, like in hepatitis or hepatitis C, may not develop antibodies, adequate antibodies. What will be the status of serology test and what should be done in our patient? Professor Sakhuja, please.
Thank you, General Verma. At the outset, I'd like to thank Mr. Raja of Microlabs Limited and General Verma for the kind invitation to participate in this webinar. Coming to the next slide, please. So coming to the lab diagnosis of COVID, the first question is, when do we really test in a patient who is under our care? So there are 2 factors that determine the need for testing. One is a travel history or a contact with an affected person within 14 days of the onset of symptoms. And the second factor is the occurrence of an acute respiratory illness characterized by fever, with cough, with or without shortness of breath. So what kind of samples do we need for testing? The usual sample that we take is a throat swab, so an upper respiratory specimen. So this can be from the nasopharynx, the oropharynx, or from the nasal cavity, and positivity rates of 32 to 63% have been reported in one study from samples obtained from these areas. If the patient is bringing out sputum, even that can be used. And in fact, sputum samples may have a higher positivity rate of up to 72%. In seriously ill patients who are hospitalized, a lower respiratory specimen in the form of a bronchoalveolar lavage can also be obtained and can be even more reliable than upper respiratory specimens. Although the GI tract has also been known to be involved, and some laboratories, some centers have reported that even the stool may be positive for the virus, there isn't much data as yet on such samples. Even though we know that the proximal tubular epithelium and the podocytes are the direct targets of the virus in the kidney, whatever samples of urine have been tested in most centers have turned out to be negative for the virus. May I have the next slide, please? So what is the gold standard for testing on these throat swabs that we take? The test that is the gold standard is the reverse transcriptase polymerase chain reaction for detection of viral RNA. And you can detect 4 different genes of the virus, the N, E, S, and the RDRP gene. The first line test is testing for the E gene. The confirmatory test is the RDRP gene. And if you want additional confirmation, you use the test for the N gene. Now, it's very important to emphasize here that biosafety guidelines need to be followed during the collection, transport, and processing of these samples in the lab, so that there is no risk of transmission of infection to the workers collecting these samples and processing them in the laboratory. The cost of this testing is approximately rupees 4,500, and each PCR test takes about 2 to 3 hours to carry out. Now, the next slide, which you are now seeing, refers to the point of care tests, which are of 2 kinds. The first one is the detection of virus proteins or antigens in the respiratory tract samples. For instance, in patients with dengue, you test for the NS1 antigen. So similarly, you can test for virus antigens in these throat swab samples. And the second kind of point of care testing is the testing for antibodies in the blood or in the serum. Now, when you're testing for the antigen, the results can be obtained within 30 minutes, and the testing is much cheaper than the polymerase chain reaction. However, the sensitivity can be variable. There is very limited data available as yet. There can be false positives because of sharing of antigens with other coronaviruses. And therefore, this kind of testing is currently recommended only in research settings. And if in future this is found to be reliable, this can reduce the need for polymerase chain reaction testing. The next slide, please.
Okay.
Next, coming to the antibodies that we test for, the antibody testing response depends on the age of the patient, nutritional status, the severity of the disease, the medications that the patient is on, and one very important factor is the duration of symptoms. Because the IgM antibody becomes positive somewhere around 10 days after the onset of symptoms, and thereafter show a rising titer. False positives are again possible. The IgG antibodies become positive at 10 to 14 days, and the titer thereafter rises to more than 4 times that seen in the earlier phases. These antibody titers are critical to support vaccine development and to ensure that the vaccine is really working. What kind of antibody response will be obtained in patients who are on dialysis or who are transplant recipients? We know from our experience with hepatitis C and B that many of these patients may not mount a good antibody response, and in such patients, we may have to depend on the nucleic acid testing alone. Whether these antibodies are protective or pathogenic, we really don't know as yet. Now, coming to the positivity rates of the two antibodies depending upon the timing after the onset of manifestations, IgM antibodies are positive in only 29% within the first 7 days, but are positive in 73% within 8 to 14 days, and in 94% at 15 to 39 days after the onset. In contrast, IgG antibodies are positive in 1 to 7 days in only 19%, in 54% at 8 to 14 days, and in 80% in 59 to 37 to 39 days after the onset of symptoms. And finally, yes, coming to the next slide, what are the other lab tests that one would like to do in these patients? You'll obviously look at the CBC. The WBC count is usually normal in most patients, but the differential count exhibits a striking lymphopenia, and in patients who have severe disease, the neutrophil to lymphocyte ratio is generally more than 3.1. The platelet count may be slightly below normal. Liver function tests reveal a low albumin level, elevated bilirubin and transaminase levels, and you also can get elevated LDH levels because of organ-specific injury. In patients with AKI, the creatinine levels are elevated. In many patients who have a lot of inflammatory markers, the CRP, ferritin, and interleukin 6 levels are elevated. Troponin levels may be elevated. D-dimer levels are elevated, and the prothrombin time is prolonged. The procalcitonin levels remain normal unless there is associated significant bacterial infection. Obviously, you're going to need regular monitoring of the oxygen saturation, the arterial blood gases. You'll require X-rays of the chest. You may even need an HRCT to delineate the radiological findings in the lungs better. You need ECG for monitoring of the QTC interval. You may need echocardiography to monitor the cardiac function, and blood cultures to look for superimposed bacterial infections. You need urine examinations to look for proteinuria and hematuria. And in rare instances, you may also need to look at complement levels and look for antiphospholipid antibodies. The last slide, please. And how does one confirm that the patient is now cured or totally non-infective and therefore can be discharged from the hospital? So you need to do a PCR on the throat swab again. And if it is negative on 2 samples on 2 consecutive days, then you can declare the patient as cured and non-infectious. Thank you very much indeed, and I'll be happy to take up any questions that come up during the
Thank you,
panel.
Professor Khuja, for a wonderful and a very brief mention about the test and what you are trying to mention, that possibly we will remain dependent on reverse transcriptase PCR only. Now, the last speaker, but people are looking forward to hear him, is Professor Vijay Kher.
So Dr. Varmaji, just to interrupt for a minute, there are about 26 questions so far on the panel. So just wanted to remind you, we'll take it up at the end.
All right. So I'll request Professor Vijay Kher to talk about renal transplantation. There are varied questions, and some of the questions which are coming, which I've been going through, people are asking, is there any drug which we can give? What should we do in transplant patients? Should we stop immunosuppression? Should we reduce immunosuppression? And how we should go about that? Professor Vijay Kher, please.
At the outset, I must thank Mr. Raja and General Verma for giving me this opportunity to talk to you. Good evening to everybody. Well, transplantation, before I start about the transplantation and the COVID infection, I think it's very important. We may be talking about today, this is an extremely dynamic kind of a field and changing every day. So you never know as to what is going to be new tomorrow. So keep tuned and you will see new information coming. So what I may be speaking right now may change totally in few days' time. Next slide, please. The agenda I have is that the general guidelines related to kidney transplantation, guidelines for disease kidney transplantation, living donor kidney transplantation. What should we do for transplant recipients? What's the overall experience of COVID infection in transplant patients, and drugs, if any, which Dr. Verma was talking about? Is there anything good for prophylaxis or for treatment? Next one, please. I have taken the transplantation guidelines which were published in transplantation. This is the TTS guidelines actually. And they say that actually this is an infection which spreads from patient to patient and patient to healthcare worker and healthcare worker to patient itself. So human to human transmission. So therefore, you need strict infection prevention practices. Next, please. So over the next few slides are basically the guidelines which the Transplantation Society has given. And these may change. There are no travel at the moment happening across the world, most of the places. So all patients who have returned from countries with more than 10 infected patients and have been exposed to a confirmed or suspected case of COVID-19 within the previous 14 days, they should avoid elective clinic visits or any procedure, surgical plans should be in place if there is a laboratory testing which is required during the 14 days in such a way so they avoid potential exposure to the other patients. So it's important to keep the general guidelines about testing and other things also intact in these patients as well. Next one, please. Patients who are suspected COVID-19 or who require testing to rule out COVID-19 should wear a surgical mask, be placed in isolation, have evaluation and testing coordinated in infection control or transplant IDP, which are consistent with the local guidelines as such also. Every country has given guidelines for these, and therefore these guidelines need to be followed. They may vary from state to state as well as from country to country. Next one, please. This is true also for the staff who have traveled and those people who have traveled and where they have traveled to a country with COVID infection, or where there have been confirmed cases, or there is a suspicion of COVID infection within the last 14 days, then they need to be quarantined as of now for our guidelines in this country, and can be seen the patients only after 14 days, and then COVID, they've been found to be COVID negative or didn't develop any symptomatology. Next one, please. Teams that follow local health department guidelines for isolation, quarantine, testing, and monitoring, especially for people who have returned from these endemic areas. Next one. Now, for disease donor, the Transplantation Society suggests that persons who have returned from countries with more than 10 infected COVID patients or have been exposed to a patient with confirmed or suspected COVID-19 patient within the 14 days should not be accepted as a donor. So many countries have in fact suspended, especially the ones where there is heavy COVID infection rates. Most of these people have suspended doing deceased donor transplants for time being, as well as living donor transplantation. Only emergency living donor transplants are being done, and these are also very few. So by and large, the guidelines at the moment suggest that we should suspend transplant programs, both diseased as well as living donor transplantation. And the guidelines for the next few slides similar, that do not do transplantation, both diseased and donor transplantation in areas where there is active COVID infection in large number of patients. Next one, please. So I will go over the next quickly. Next one. Next one. Next. When I go over them quickly, because they are predominantly a same kind of things, that there should be a suspension of living donor transplantation also. And then many countries have necessitated that if we do a transplantation, then both the donor and the recipient must be tested for COVID RNA testing. And once found to be negative, only then they should go ahead and do a transplantation. Next one. In countries with widespread community transmission, temporary suspension of the living donor kidney and liver transplant program should be considered when donation can safely be deferred to a later date. Next one. Where available, testing for upper and lower airway specimens for either by PC or by NAT of donors where there is a concern for COVID infection, it should be considered. And some national guidelines recommend routine testing for donors as well as recipients for COVID-2 infection. Next. Next. If transplantation is required life-saving procedure, then it can be done. But by and large, most societies have recommended at this point of time that in countries where there is COVID infection occurring, transplantation programs should be suspended. Now, what should be done for transplant recipients? Like all persons, transplant recipients should adhere to travel advisories issued by their respective health authorities and government bodies. This may necessitate postponing travel to countries with more than 10 infected patients. Recipients should avoid travel to all locations where there is COVID infection currently, and transplant recipients should avoid all cruise ships. Next one. The Transplantation Society also suggests that transplant units should be prepared to receive patients who, for various reasons, have been abroad. They should be housed in single rooms with attached bathroom, and all staff attending to them should be in full PPE until infection with COVID-19 is ruled out. Close liaison is needed with the departments like infectious disease as well as radiology, whose services might be needed in these patients. Next one. An effort to rearrange scheduling of patients must be needed for their appointments in the unit. The incubation period, the asymptomatic negative PCRs early in the course of disease combine to make out ruling out a patient who has a COVID infection extremely difficult. So therefore, one must, as Dr. Balla said, for dialysis patients, that at the moment we must consider all patients to be COVID positive because we are not testing everybody, and therefore it's very essential for us to consider them to be COVID positive and use all the precautions for the patients as well as for the healthcare workers, so that they should wear a mask, hand washing, social distancing. All of these must be taken care of in these patients as well. As these patients are more prone to get infection, and once they get infection, they are at high risk of getting severe infections, as well as there is high mortality in these patients, as we will see. Next one. The transplant patients who have fever or respiratory symptoms should be. Can I go to the previous one? Vinay, previous one. Yes. Transplant patients with fever or respiratory symptoms should be instructed to call the transplant center and avoid presenting to the center to avoid inactivity. They must got into the emergency in an area where they can be seen and a possible COVID infection ruled out before they can be examined as regular patients. Transplant centers should also develop guidelines for symptomatic patients if they need evaluation, testing, and management. And of the countries at this point of time in March, and they are likely that they might get changed again very soon. Next one, please. Now, what has been the kind of an experience? Next one. Vinay, next one. Yes. What has been the kind of experience of transplant centers? Can I go to the previous one? I think there's some problem with the moving the slides. Can I show this? Yes, yes, stay there. Well, there have been two studies not yet come into the print, but they are in the pre-print state. If both are in Kidney International. One study came from St. George's Hospital by Dr. Banerjee and Punish, who worked with us. These were 7 patients who were admitted in St. George's St. George's Hospital in UK. 2 patients were, these were transplant recipients who developed COVID-19 infection. 2 patients were managed at home. 5 patients were hospitalized. 4 patients required ICU admission, and 1 out of the 7 patients died, which gives you a mortality of about 14%. This is another study which is of 20 kidney transplant patients. This is from Brescia, Italy, and These are 20 kidney transplant patients, and you can see that in majority of these patients, immunosuppression was withdrawn. 87% of the patients had worsening of the chest X-ray. 85% of the patients, 11 of the 13, where the immunosuppression was withdrawn, escalation of the oxygen therapy occurred. They were given dexamethasone in 11, tocilizumab, which is an IL-6 receptor anti-IL-6 monoclonal antibody was given in 6 patients. Methylprednisolone, lopinavir, ritonavir, out of these 20 patients
Doctor, we are not
were
able
in the
to hear you
ICU.
properly.
6 developed acute kidney, 5 out of the 20 patients. Sort of experience that we have so far in the literature. Patients from Italy and 7 patients from this year. What is quite clear, patients have a general more in this patient.
Professor Kher, your voice is breaking.
But in the
Dr. Kher, your voice is breaking, so maybe some signal issues. I think we lost his talk. I think we lost his connection. Vinay,
maybe, yeah, I can see him. Maybe the internet is slow on his side. So.
Sir, in the meanwhile, Dr. Vermaji, you would like to take up 1 or 2 questions?
Professor Kher, is Professor Kher with us?
Hello.
Yeah, please go ahead.
Hello.
Yeah, you are audible now.
Hear me?
Yeah, we can hear you.
Okay. The next slide actually is the last slide. See this, and Dr. Verma has also said that are there any drugs which can be given to transplant patients? And as you had seen that actually the Italian experience suggested that that they had given, these patients were very sick, and they have been about 6 patients. They had withdrawn immunosuppression in majority of the patients. In the St. George's Hospital, they had reduced and they had a response if these patients were COVID infection. I think we should the mycophenolate mofetil or the azathioprine, if these patients are on those, we should reduce tacrolimus and maybe probably increase steroids for some period of time, like we do for any other infection. There are centers which have withdrawn immunosuppression. There may be partial reduction of immunosuppression. And one should know that once these patients get better, when should you get them back on these immunosuppressive drugs is not very clear from the studies as yet. But like we treat any other patients, once they recover their function significantly and the infection looks to be better, then probably one should start, at least if the tacrolimus was withdrawn, one should go with tacrolimus to first with, and then maybe later on introduce the mycophenolate mofetil. That needs to be done. Obviously, these patients need to be isolated. If these patients become sick, then obviously other therapies may be needed, like for acute kidney injury, supportive care, and rest of the care might be needed. Next one, please. Well, the drugs we've been used, as you had seen in the studies, is chloroquine, hydroxychloroquine, azithromycin, Remdesivir, there is a study which came in New England Journal of Medicine that remdesivir may be the drug. People have used other antiviral drugs. Ivermectin has also been, at the moment, we do not have any randomized trials, so we will not be able to say that which drug is effective. Fortunately, as Dr. Sunil Prakash said, that there are a large number of randomized trials which are going on. Drugs like remdesivir and antiviral drugs, hydroxychloroquine, these all in randomized trials. The drugs including losartan and angiotensin receptor blockers, Dr. Verma was talking about it at that program, suggesting that these drugs may have some positive effect. And people are even repurposing, sort of trying to look at newer drugs which could be beneficial. And azathioprine, in fact, has also been found that this may be a drug which might be effective. And it would be very interesting to see data that transplant patients who are on azathioprine, have they behaved differently and those who will relate Mocktail and other stuff. So with this, if there are any other questions, then we would be able to do such. Be glad to do that. Thank you very much.
Thank you very much, Professor Kher. So what I think before we go to question answer, you can summarize what we know today is possibly reduce immunosuppression in a transplant patient if he develops COVID infection, and your recommendation will be cut down MMF, reduce Tecro, carry on with steroids, and at a later date, once the person is all right, we reintroduce them. Is that what you will recommend now?
That's what would be. That's what we do for other infections as well. Severe infections, we would stop the proliferative, anti-proliferative drugs like mycophenolate mofetil or azathioprine, and continue tacrolimus. Steroids have been used, and many people have said that steroids may be useful in patients with COVID infection. So there is a debate going on about that. I think I would continue with a slightly higher dose of steroids, reduce tacrolimus, take off mycophenolate mofetil, and till they get better. Hopefully, we should be able to, if they are not very severely symptomatic, we should be able to manage these patients in home isolation, and they may not be hospitalized. But those who are sick enough, they might have to be hospitalized, and those who need ICU admission might have to be taken into the ICU.
Okay. I think I'll start with Professor Sakhuja. There are a couple of questions. One is how the false positive is there in IgM in COVID cases. Number two question is, will you recommend routine screening of patients who are coming for dialysis from other centers?
Taking the second question first, because that's quite straightforward. We had taken a decision at our center not to accept any new patients on maintenance dialysis at our center during the period of this pandemic. However, that does create practical problems for patients. Obviously, they cannot be denied access to dialysis. So that may not be the correct decision in all instances. I think if you want to accept a new patient coming from another center on your maintenance dialysis program, what you should do is make sure that he has no travel history to an area which is seriously affected, or a contact with a known patient, and has no symptoms to suggest COVID-19 infection. And in such a situation, I think the patient can be accepted. Of course, if you have any doubt about a COVID infection in such a patient, then do the usual tests and only then accept the patient onto your program.
False positive IgM?
False positive IgM. See, what I'd like to emphasize as far as the antibody testing is concerned, that as yet, the information, the data that we have with regard to antibody testing is really very scanty. We are not even sure about the source of those antibody kits. Even in India, the antibody kits have just become available maybe a day or two ago. Until then, they were not available. So we really have no data on patients in India that we can rely on as yet. Some of these kits are coming from China. Some of these are probably manufactured by Abbott. So we really don't know about what the performance of these kits is going to be like. So it's only once we have more data that we'll really be able to be sure about the reliability of antibody testing, whether it is IgM or IgG. So at the moment, to say that we'll be able to give you reliable answers on antibody testing, I think it's not possible.
Thank you very much. Dr. Bhalla,
Yes.
there is a question. How will you give HD as a OPD case to a COVID positive patient? And second is, do you recommend the heparin dose should be increased because people have started noting that the clotting is more in COVID positive patients? Do you recommend those?
As I already mentioned in my guidelines,
please scan the questions so you can take over and start.
As I already mentioned in my guidelines, if you have a COVID positive facility separate from your main negative unit, that is the ideal situation. If you have a COVID positive separate facility, if that is not available, then second is a separate room in your parent hemodialysis unit with all PPE precautions level 3. And if you don't have even that, then last shift of the day with formalization and sanitization.
I personally feel the question what has come because this situation will not be there for a very long time.
Yes.
If a person is COVID positive, possibly it is a question of days and possibly he will be requiring hospitalization most of the time because this is a matter of couple of days. Either the disease will clear off or he will succumb. So possibly this question may not be very relevant, but as you rightly said, if possible, we can give it in isolation.
Yes, but otherwise ICU admission, otherwise what practically what we will be doing actually is that if these patients are in ICU setting, then these patients will be getting dialysis in ICU.
Right. Now, heparin dose.
Yes, there is no recommendation for increasing that, giving higher doses or giving TPA or other therapies in these patients. That is only being used for AKI in ICU settings, cytokine storms, but not in maintenance hemodialysis patient and anticoagulation.
Right. To Dr. Sunil Prakash, there are 2-3 questions.
Who have D-dimer positive.
If D-dimer is
positive,
very high, then
yes, then you may require more heparin.
Sir, those patients will be in ICU setting, having not in a maintenance hemodialysis patient.
Not maintenance.
Now, I don't know what Dr. Skhuja earlier answered. The policy in Delhi, at least in our center, is, I must share, that no outside patient will be accepted for hemodialysis unit.
No, I think this is a policy. Dr. Bhalla, most of the centers are adopting that. But you are also aware, few of the centers have got closed.
So Dr. Verma, let me complete. Because these patients are coming from the centers which have been closed.
Yeah.
So now these patients are wandering around different centers. Now, if God forbid, if this patient becomes positive, and today you have even tested, and on test this patient is negative, but he is still incubation period, it is very likely that he has already contracted infection in that previous center. So I agree with Dr. Skhuja's initial part, first part, that it is better not to accept. We are having 200 plus patients on maintenance dialysis in our center. You are risking the closure of your center just for this one patient addition. I will strongly support that view. Or what we are doing is we are keeping this patient for observation in our fever clinic, and we send in a asymptomatic patient. I'm saying we send the COVID test. If we send in the morning, we get the report in the evening. once we get the negative report, we accept this patient on dialysis, but then you have to repeat this test after 5 days or 7 days.
I think the answer is pretty clear. What you rightly said, that you might be forced to accept, but accept it after doing a test, and again you are retesting. Yes. Dr. Sunil Prakash, the questions are a couple of questions. One, people want to know, let's be very clear, is there increased risk of AKI or not? Number two, if the risk of AKI is more, patients who require HD, do they have higher mortality? Number three, any drug you will recommend for critical cases?
By design, I put in all papers because the jury is not yet out about the prevalence of AKI in COVID, and the European data and the US data is yet to be brought to print. We have only Chinese data to look back upon. But if I have to rationalize in one sentence, I would say the prevalence of a pure AKI is around 4.5, 5.5, something like that. Please remember that most of these patients have comorbidities like diabetes and hypertension, and they do have some mild CKD. That is why in slides, you must be wondering that proteinuria and hematuria and deranged KFT was like 15 to 20%. But in Lang study also, they said AKI is 4.5%. So to reiterate, pure AKI would be anything between 3 to 7%. A mean would be, say, ballpoint answer would be 5%. But there is going to be a huge variation, and we must wait for the European and the US data to get a bigger picture. That is one thing. And the second thing is, it was about what, General Verma?
Any drug you will recommend for critical cases?
No, I really am not convinced about the data which is still there. People are giving HCQS and azithromycin because they are available and they are cheap. But we have not yet have any evidence to suggest that these things will help. I think once the patient reaches in critical state, which means that he is on continuous renal replacement therapies, or he's on cytokine removal, he's on ventilation, he's on prone ventilation, he may not be on ECMO. We all know that there is a very, very guarded prognosis in these patients. So in ICU setting, as of now, I'm unable to recommend any drug.
All right.
What about convalescent plasma? I think that is something that is now going to be the subject of randomized controlled trials.
Yes.
So
number one, and number two,
worth considering.
Number two, I agree with
because the antibody test is just appearing in India, and it is only once the antibody test is there, you are able to test that people who have recovered and they have got enough antibodies. Only then the plasma can be taken.
Yes, IgG antibody.
Yeah, Professor Kher, I think you can start the questions.
I'll just finish one more thing. There's a very interesting paper from Keith et al., and he has done plex in these patients, and a study of 20 patients, and they have shown some better results in such critical ICU patients. Plex.
Professor Kher.
Yeah, I think one of the questions is that if a COVID infection occurs in the transplant recipient and the patient is within the 3 months of the transplant, and in fact, actually, both studies which are about to be published, one is St. George's study, 2 patients out of the 7 were within the first 3 months of the transplantation. And even in these patients, I can understand the person who asked probably is asking that when we are talking of stopping mycophenolate mofetil within the first 3 months of the transplantation, the chances of a rejection and all that. But when we are talking of an infection, severe infection like COVID or any other such severe infection, I think it's very important for us to save the patient rather than worry too much about the rejection. At that point of time, it's important to take off mycophenolate mofetil, and I would continue with the sort of guidance that was done. And this is exactly what was done in St. George's experience also. They stopped mycophenolate mofetil and they continued only dual immunosuppression in these patients. And 2 of these patients were within the first 3 months. Even in the Italian experience of 20 patients, about 3 patients were within the first 3 months of this also. And they had discontinued immunosuppression in these patients because 2 of these patients were quite sick and one of these 3 patients died. Otherwise, other 2 patients in whom the immunosuppression was taken off, these patients recovered and all that. So I think it's very clear that the response in patients who develop COVID transplant recipients, I would cut down the immunosuppression, stop mycophenolate morphine. That would be okay.
Dr. Kher, are you convinced, and Dr. Bhalla, are you convinced that the CKD patients have got a minor disease if they are infested with COVID?
At the moment, I think the experience of whatever is published suggests that they don't. And it's quite possible that because many of our patients do not have immunologically very competent, they are immunologically suppressed. And a lot of damage which occurs in patients with COVID infection occurs because of the immune reaction and the inflammatory reaction which occurs with these patients of the immune attack that the body launches and the cytokine storm which occurs. Many of our patients may not be able to launch that kind of attack. Obviously, this is variable.
The question is why this scenario not in transplant patient? They are also same disabilities they have got.
Yeah,
they are also immunocompromised. And mind you, one of the center, I was talking informal talk in US, they are believing that this immunosuppression should be continued. They feel that by continuing immunosuppression, we might be able to salvage patient because then they will not mount the antibody response. I mean, there are different theories. Anyway,
yes. Now I don't know. I think the jury is out. I don't know whether we know for sure as to what is the experience of dialysis and CKD patients. We will have more data. This is only a small kind of a data. All data is at the moment from China, so we do not know what will be the kind of data which will be coming forward.
One question, Professor Puja, is coming. What do you? I mean, we are not the horoscopist and we cannot read the future. People are asking, what do you read about the pandemic? How long it is going to continue? And the corollary to Dr. Kher is that after Dr. Sakhuja, that if this is continuing for over 2 months, 3 months, what do you think, when should we restart transplant with due precautions?
I think it's extremely difficult at the present moment to predict what is going to happen in the near future. It's more an expression of hope and optimism that I'm saying that maybe in the next 3 or 4 weeks, we'll see a decline in the number of infections in our country. And then the lockdown can be opened up in stages. However, I'm not at all absolutely sure of that. I think I'm very uncertain as yet.
Yes, I would agree with Vinay that it's very difficult to predict as to how this is going to pan out. But knowing from previous pandemics as well as epidemics, this virus is here to stay. I don't think it's going to go away till we find either a vaccine for this or a drug by which we can reduce the infectivity of this virus drastically. So I think we will have to, over a period of time, I don't know how soon that is going to be. I do hope that the lockdown produces at least the kind of an expected effect that most of us and the Prime Minister and everybody else is wanting, is to reduce the number of infections to such levels that we might be able to have a staggered, a tiered kind of reinitiation into our practice. And I think I would feel that we will have to learn to live with this virus and deal with this virus like we have done with other viruses as well, although they were not as infective like H1N1, but that wasn't as infective, that didn't go into this kind of a proportion of pandemic. But I think ultimately a herd immunity has to develop till we get the vaccine, and we will have to deal with it. I think we will have to,
Yeah,
the way we will have to practice will be different now. It will not be the same. I don't expect that we are going the masks and the hand washing and the other precautions that are currently going on will have to be a way of life for us for another 6 months, maybe a year or so too, till we get a vaccine. That's what I would predict.
right, right. Now, the question to anyone, because some of the people have asked, personal experience of any patient, any of your our patient had COVID positive, dialysis or transplant. I can say one of my patient of dialysis had COVID. Actually, he was not on dialysis. This gentleman, 80-year-old, had come to our hospital last week, to be exact, 7th of last month. Today is 14th. I examined him on 7th, 8th, and 9th. The chest X-ray was totally clear when he came. He had not started the dialysis. We thought that the first uremic encephalopathy. We dialyzed him on 7th and 8th. 9th, we suddenly found X-ray which was totally clear. It became totally flooded. So that is when we suspected. We got an X-ray done. X-ray, we had seen that, and that is the day there was a severe lymphopenia. And before we could do anything, patient was shifted to ICU. By that time, COVID test was not there. He was ventilated. Eventually, he died. And I am also in quarantine for him, as a matter of fact. So there are anybody having personal experience with any COVID transplant or dialysis patient.
We had one patient in ICU, not admitted under us, but we were on call. So we dialyzed that patient, and we had given only one dialysis. And once the report came positive, it was referred from other hospital, where this patient was there for about 20 days. So within 24 hours, we made the diagnosis. We gave him only one dialysis, and after that, referred this patient to RML hospital. From where this patient, the attendants took this patient Lama, and then ultimately died. So, but the whole ICU staff and our technicians and doctors were in quarantine, but luckily all of them came negative.
Any other experience with?
Yes, one of our patients also, dialysis patient, had COVID positive, but he did well, and he is on dialysis. He is still admitted in the hospital and getting dialysis done. We have a COVID ICU, and we are dialyzing him. Although he's on the floor, we bring him down, and we have, like Dr. Balla had talked about, one separate wing is created as a COVID positive wing, and the elevators and all the entries are different in that wing, and so he gets dialyzed in that side, and that's how we are dialyzing. But he's doing well.
Dr. Kher, what were the presenting symptoms of that patient?
That patient had pneumonia and cough and fever.
Dr. Sunil Prakash, the question is, has any patient, literature-wise, COVID patient presented with nephritic or nephrotic illness? And if such a patient...
Yeah, there is a autopsy which has been done in I was reading it somewhere, and they found that collapsing FSGS, as well as they demonstrated the virions in the podocytes as well as in the tubular cell, like Vinay had also talked about.
Yeah, this is collapsing. African, this was the African and American.
FSGS.
Yeah, this case report came.
Yes.
I just want to add 2 points. Am I audible?
Yes.
Yeah, you are very much audible.
Yes. I'm just wanting to add 2 points, that in transplant now there are a lot of papers which are coming, which are suggesting that CNI should be kept on the upper normal side, and cyclosporine may do better than tacrolimus because of the path which cyclosporine takes is less affected by the COVID interference. And number 2, when we end up doing dialysis of such patients in ICU and critical care wards, we are not to be guided by BU and creatinine levels. Our guidance should be by hydration. these people land up into overhydration states, which are getting worse by their need to keep in prone positions and further interventions and so on and so forth. So they have to be kept little volume deplete to save the lungs. Here the priorities will go to the lungs. These are the 2 points I wanted to make.
Dr. Professor Kher, any questions other you would like to?
No, I think that
Dr. Verma,
it's
someone
already
has
about-
asked. Someone has asked about one question: how much is the incidence of viremia?
Right. Incidence of viremia.
Yeah, in these patients.
Professor Sahuja, any literature on that?
No, I really don't have an answer to that question. And in fact, testing on blood samples has not been recommended.
Yes.
The PCR is done on the upper respiratory samples, but not on blood samples. So most likely, as far as I'm aware, blood samples will be negative in most patients.
Right. Mr. Raja, is there, can we, anybody, audience, if somebody wants to ask any question, do we have a provision?
Yes,
yeah, they can
yeah,
raise.
Dr. Chittaranjan Kar is online.
Yeah, anybody.
Wants to ask.
Last 5 minutes, I think we should give to them.
Correct. Yeah, Mr. Vinay, can you just unmute?
Good evening, everyone. Am I audible, sir?
Yeah,
Yes,
Mr.
yes,
Dr.
yes.
Chittaranjan, you are audible.
Yeah. Sir, I thank all the panelists for a very lucid illustration of these topics. I just wanted to ask one question to Professor Vinay Sakhuja. What about the resurgence of cases in South Korea and some cases in China, that they are again testing positive after they have tested negative twice? So what are the possible causes for that, and can that phenomena also happen in India?
I'm not aware of what you are talking about, but it is possible. As I mentioned earlier, it's not really known whether the antibodies that we develop are protective or not. We are not yet sure about this, and only time will tell whether the development of an IgG antibody is truly protective against future infection or not. The answer to the question that you have asked depends on that precisely. And I don't think we have a clear answer yet.
Any other question?
There is one. Yeah. So there is one question from Dr. C. Arvind. Right. He talks.
Dr. Kanchi, is he there?
I think he is not, but he has typed. He has left the question. Today, the UK Renal Registry has published data that shows a high prevalence and mortality related to SARS in dialysis patients. 926 new cases of SARS have been identified this week in dialysis patients with a mortality at 2 weeks of 15%. Given this, shouldn't we classify patients as normal, suspected COVID positive patients and have 3 separate areas for dialysis? This is a query from Arvind Kanchi.
No, this is not a query. He has made a comment that possibly what we are trying to say that the disease is milder in patients on dialysis. He is mentioning that there's a study of 926 patients where the death rate is almost 15%. You said, I have not read that.
Yes.
Yeah.
Yes.
Yes, mentioned as 15%.
15%.
Yeah.
Yeah, that's what I was talking about, that we do not know yet. This was the Chinese experience and some of the studies which have been published, but there is going to be a huge amount of literature which is going to change. And I think, I don't think we can make any comments at the moment about whether the disease is going to be mild in patients with dialysis or so. At the moment, the studies which we looked at did suggest that that's so, but more data might come from the Western world, the US, as well as from the Italy as yet, and they might talk of totally different kind of outcomes in these patients. So we will have to keep tuned to new information.
This is a question for Dr. Sakhuja. Will the IgM antibody cross-react with other viruses like influenza or rhinovirus? Putting it another way, what is the antigen target for these IgM or IgG tests, and the
Yeah,
role
that-
of convalescent plasma infusion?
Yeah, convalescent plasma we already talked about. A definite role is not at all as yet established, but centers are already starting trials of convalescent plasma infusions in seriously ill patients. And I am told even the PGI is planning such a trial. But we really don't know whether this will work or not as yet. As far as IgM antibodies are concerned, yes, the possibility that these can be false positive has not been ruled out, because it's possible that there are shared antigens between COVID-19 and other coronaviruses, or even viruses other than coronaviruses. And so that possibility still cannot be ruled out.
Thank you very
I
much.
think there was a question about continuation of ACE inhibitors or ARBs in patients, because you did talk about
Yeah,
the ACE2 getting overexpressed
the
especially in
recommendation
patients
will
with that.
remain.
But
that
I
we
think the recommendations at the moment are that we should
Continue.
continue this. The European guidelines as well as the American Heart Association guidelines
Yeah,
also
they
suggest
recommend
that we should
continue this.
continue this. I think
We don't
for
know
those
how
of
they are
you
beneficial, but they are
Yes.
beneficial. Rather, there is a
In
trial
fact,
which has started of using
losartan,
in patients.
losartan, I told you,
Yes.
there are some newer drugs which are looking at. People were talking about immunosuppressive drugs like cyclosporin being better than tacrolimus, but I think drug which is of interest would be sirolimus, because that is been shown to be a drug which might be has antiviral activities and maybe a useful drug to look at in COVID-19 infection. Mercaptopurine has come out as a drug which might look like to be a good drug. So it would be interesting to see. I talked about it, that what happens in patients with azathioprine and all that. So it looks like that some of these newer drugs might produce beneficial effects. We don't know yet.
I think there are many questions. There are, I can see 67 questions still lying. Mr. Raja, do we have time or we have to wind up?
Maybe another two questions we can take up, sir. One frequently question I see is that regarding the use of ARB and ACE.
That answer has been given by Professor Kher, that the recommendation by American College of Cardiology and European Society of Hypertension and Cardiology is continue ACE and ARB if a person is taking. The overexpression of these ACE receptor is beneficial. If you block or delete the ACE receptor, the disease is more severe. Anyway, we will go for last three questions. Let me see. I think this has been answered. Dr. Indranil Ghosh is asking, is there a role of plasmapheresis or immunoadsorption followed by plasma infusion? Dr. Sunil Prakash.
Plasma exchange there has been a big paper by Keith et al., but Dr. Sakuja had already pointed out about plasma infusion. And at this point of time, at least there are some good papers which are suggesting its convalescent role, but we have to be look out for more data to come up, both for plasma infusion as well as plasma exchange. But I believe plasma infusion will really help these very heavily immunocompromised patients.
There is a question.
Why more young population is infected in India?
Because India is a young population country.
Yeah, younger nation of younger people.
Yeah.
So what you have will get infected.
Professor Sakuja, does this sputum PCR need specific collection method?
No, the only thing that you have to be careful when you are taking the sample is that the swab should touch the posterior pharyngeal wall and take the sample from there. So it should not just touch the tongue or the palate and take a saliva sample. That would be relatively unlikely to be positive then. You'll get false negatives. So the sample should be from deep inside the pharynx. And what people have advocated, so that the patient does not transmit infection to the staff and to other people around him, that there should be a drive-in facility to the collection center. The patient drives to that point, opens the window pane of the vehicle, opens his wide mouth wide as possible. The collection staff takes a deep pharyngeal swab, and then the patient drives out of the area, so that there is minimum exposure to anybody else. So that is the main thing that has to be done carefully.
Sir, is the swab taken from nostrils also after
Yes,
the pharyngeal
yes,
collection?
Yes, you
both,
can take it
both.
from the nostrils also, the nasopharynx also, but the most common site, the easiest site to sample is the oropharynx.
Now, as Professor Sakhuja has mentioned, you have to take specimen both from oropharynx also, from nasopharynx also. Rather, the yield from nasopharynx is more than oropharynx. Now, last question somebody has asked, is hot weather going to be beneficial?
We hope.
That's
We
the
hope.
million-dollar
We hope.
question.
We hope.
Time will tell.
Sir, one question from Dr. Pankaj Hans. Any
Please.
data on usage of DAA against HCV usage in vitro patients? Any data on usage of the DAA against HCV usage?
There are other antiviral drugs which have been used. Remdesivir has been used. Ritonavir has been, lopinavir has been used. So these are drugs, but we don't know. In a randomized trial, they have not been yet shown to be effective. So we don't know whether they are effective.
It was yesterday only the study came in MEJN, where they tried in 199 patients. 100 were given control and 99 were given these antiviral. But the result was there was no benefit. Though the people who received antiviral, they claimed the recovery was 1 day earlier, but it was insignificant. So at the moment, there is no recommendation. I think we should close now.
Yes, sir.
And it has been, I have been
Yes,
honored by the presence of such illustrious faculty who have been very cooperative and who have answered. The talk prepared by them was superb and they delivered in a fantastic way. I'm grateful to all the faculty
Thanks to all
members.
listeners.
Thank
I
you.
also,
All the best.
Sir,
Thanks for a great webinar. Thanks
I
everybody.
also on
thank
behalf of
Mr. Raja,
yes,
I think Microlab, for organizing this and giving us an opportunity to be here. I hope with the new knowledge which will be coming, and there are many areas which need to be covered, possibly after 3 to 4 weeks, we should have another webinar to whatever recent or whatever latest has been learned. I hand over to Mr. Raj.
Sir, once again, to all the panelists, speakers, as well as the audience, it's indeed a pleasure for us because there have been a lot of such COVID programs happening across various specialties, particularly in ID and intensive care specialties. But somehow in nephrology, we thought that there's a need for us to really take it to the widespread of knowledge. So that's a small initiative from Microlabs. I really thank the entire audience for sparing your valuable time and the time taken by all the speakers in preparing their slides within a short notice. So I thank once again all the speakers as well as participants for enlightening us. And thank you very much and have a wonderful week ahead. Be safe, be stay at home. Thank you very much. Good night all.
Thank you.
Thank you very much.
Thank you very much.
Okay. Thank you, Dr. Verma.
Thank you, Dr. Balla. Thank you, Sakhuja sir. Thank you, Dr.
Thank
K.
you.
Thank you,
Thank you
Dr.
very
Kher.
much indeed.
Dr.
Thanks to
Sameer.
everybody.
Yes.
Thank you.